Right, good afternoon, everyone. It's a pleasure to be here in Coimbatore, and glad to see such a large audience post-lunch. Now, I'll play a bit of a villain here today with this topic, especially post-lunch, but I'll try to keep you interested throughout. Right. So what we're trying to do is we're going to try to understand the reasoning why we give certain volumes of local anesthetic to create a regional nerve block. Now, how many of you use a stock 20 ml syringe, fill it up with local anesthetic and give it with most of your blocks? I do. Do all of you do that? Most of us do that, right? 10, 20 mils, and we just do a block and be done. So what is the basis of this? Now, we have a nerve, and we'd like to think that if we do the injection, we flood the surroundings of the nerve with a local anesthetic, and on a good day, this nerve decides to suck up all the local anesthetic and create a nice block for you. But what we don't usually think about is that in the vicinity there are vessels, there's vasculature around nerves, and there's muscular tissues which are also fairly vascular, and these compete for the local anesthetic. So it's not always the entire volume that goes into the nerve. If you're having a really bad day, you might enter the wrong facial plane, and all your local anesthetic will go the wrong way. So in the old days, when we weren't very precise and the deposition of the local anesthetic was not as accurate as it is with ultrasound today, we would compensate for this lack of skill or this lack of technique by flooding the area with a very large amount of local anesthetic, just to keep every bit of those characters in the picture happy. All right, so this is the basis of why we use such extreme volumes. And if you look at the, okay, sorry about that, let me just get back to that slide. Yeah. So if you look at the old volumes, the traditional volumes, for common blocks, there are reports of people using about 60 to 80 mils for things like the interscalene, the supraclavicular in the old days. And the other extreme in the ultrasound era is that of the ultra low volumes. And we have seen reports of blocks being done with as little as 5 ml or 4 ml of local anesthetic. But when we study these blocks under ultrasound, the picture is a little different. We aren't as extreme as the traditional volumes, and neither as extreme. It's a somewhere in between picture. And if you look at those numbers, they kind of wind up close to that 20 ml mark that we always seem to use. Now, are these high volume blocks that were traditionally used necessarily bad? Well, we didn't have anything better to get the block going, so we used high volumes. And this brought out, you would get the occasional local anesthetic toxicity, cardiotoxicity happening, all those bad things would happen. And even these days, sometimes we don't stop, don't we? When you've used ultrasound, we just like to create some nice fill patterns. We're not satisfied with the fill patterns. So it's another 2 mil, 5 mil, we inject a little bit more and more. So these are often unnecessary procedures that we do. What about the other extreme, ultra low volume blocks? Now in 2009, when this came out and I was kind of starting out on my ultrasound practice, this was very exciting. Brian O'Donnell managed to give an axillary block with 1 ml of local anesthetic volume per nerve. That is 4 ml in total on 10 patients with 100% result. This was fascinating for us. We were very excited. And we went into this phase where we tried to give really, really low volumes for most blocks. So how does this work? For starters, it has to be an extremely precise deposition of the local anesthetic in the right place. And the right place is still contentious 10 years later. Where these subparaneural injections? Where these intraneural injections? We don't know. They use very high concentration of local anesthetic. 2% lignocaine is extremely high for a regional nerve block. And there are few sites where we can do this. There are certain sites where we cannot do this. Are they safe? Are they reliable? if you look at literature, there is no clear benefit for reducing volume so drastically, except in one area. Do you know which area that is? We harp about this a lot, the interscalene. So a couple of years back when this paper came out, they looked at the incidence of the local anesthetic causing a phrenic nerve blockade. And they found that if you reduce the volume to as low as 5 mil, you can reduce, not completely eradicate, but you can reduce the incidence of phrenic nerve palsy. So this brought about a big change in all our practices, and what we do these days are interscalene blocks with just about, probably not 5, but you're looking at about 10 or 12 mils max to create a good interscalene block. So this is the only evidence for reducing volume so drastically in our understanding. Now, is volume everything? When we talk about blocks, we talk about volumes. We say we give 15 mils of ropivacaine or 20 mils of ropivacaine, but is it everything? Now, volume by definition is the space that the liquid, that's the local anesthetic, occupies. But there's also a drug to deal with, isn't it? So the drug contains a mass, and the mass is the measure of how much matter that local anesthetic vehicle contains. So we have different drug preparations with different levels of mass in them. And the maximum mass that we can administer to a patient is very clearly defined. We know the toxic levels of all the different local anesthetic that we use every day. The maximum mass is clearly defined. So you realize where we are. We are using a very primitive way to calculate our local anesthetic doses. We look at the maximum permissible mass and we try to stay under that, and we use that much volume and we deliver a nerve block. In this era of precision, that sounds a bit primitive. And how are volume and mass related? If you look at this, there's a very interesting paper in 2010 from Ed Mariano, Brian Elfield, where they looked at the total dose of the drug administered through a catheter. So they looked at 2 groups, both receiving lumbar plexus catheters, and they injected one group with 0.1% ropivacaine at the rate of 12 mils per hour. It's a high volume. And another group with 0.4% ropivacaine with a basal rate of 3 ml per hour. And what was common between both groups was the total cumulative dose. The total mass remained constant between both groups. And what they found was that both groups actually exhibited the same characteristics. So they looked at the quadriceps strength, the hip adductor strength, the hip flexor strength, and the femoral sensory tolerance. And if you look at this graph, they're all fairly similar. So that is the relationship between volume and mass. It is the total mass of the drug that makes a difference. So that's what I said. The mass of the drug within the vehicle is the determinant of the effects, and the high volumes of local anesthetic will have similar effects as that of low volumes if the mass remains constant. Next, you're going to ask me how much local anesthetic, how much mass do we need to create a block? So if you look at actual science, to get a successful nerve block, you need to block more than 70% of the transmembrane sodium channel populations over 3 consecutive nodes of Ranvier. And this nodal internodal distance varies from 2000 micrometers to 200 to 2000 micrometers. And this roughly boils down to about 6 millimeters of nerves with sufficient molecules to block 70% of these channels. But there's a lot of variability as to the number of molecules that are required to achieve a block. And the sodium channel density, the subtype sensitivity to blockade are again variable. Basically what it says is we just don't know how much we need to create the block. How do we determine volumes in this era of ultrasound? So one way of doing it is to actually measure the square area of the nerve. So you can use the software in the machine to determine the cross-sectional area. And in this study, they looked at the ulnar nerve, which you see here, and this, you can see the little dotted lines around the nerve. This is the software there to measure the cross-sectional area. And they used something called the up-down method of analysis from Massey and Dixon to give an initial dose of 0.4 ml per millimeter square of the nerve, reduced it by 0.04 ml if the block succeeded, and increased it by 0.04 if the block failed. And they looked at the ED50 and the ED95. And what they found in 17 volunteers, that the ED50 volume was 0.08 ml per millimeter of nerve, and the ED95 was 0.11. So the mean cross-sectional area of the nerves was about 6.2 millimeters with a standard deviation of 1 millimeter. What this meant was they were giving an ulnar nerve block with about somewhere around 0.7 ml of local anesthetic to get 95% success. Similar authors, they looked at the sciatic nerve in 14 patients, and they did the same up-down method, and the range of the local volume that they used was between 6.2 and 20.9 ml because of the cross-sectional variance. And they found that the ED99, that is to achieve 99% success in the block with using ropivacaine 0.75, was 0.15 ml per millimeter square. And what about facial plane blocks? So facial plane blocks are a completely different game altogether. They require the spread of local anesthetics to both proximal and distal points to cover a relatively large area. And this distal spread is imperative for success. You can think about it, the TAP block, the rectus spinae blocks, the quadratus lumborum blocks, they are all reliant on distal spread. And with distal spread comes great volume, so these are heavily volume dependent blocks. But do we know how much to inject? We don't. There is nothing in literature that shows that there is a science to the volume that we use. Once again, with facial plane blocks, I'm sure all of you do the TAP block and you use 15 or 20 ml on each side. Is there a science to it? Has this been studied? Unfortunately, no. So, and it's mostly expert opinions that we look at, and they say the ideal volumes for a TAP block are something like 0.3 to 0.6 ml per kg. And this isn't exactly the best thing, because the blood levels of local anesthetic at 30 minutes when you use, say, ropivacaine, reaches toxic levels. What about catheters? Do we have standardized volumes for catheter infusions? No. So once again, the doses are largely guided by the maximum permissible mass that is allowed. And we have, like I said, we have good data on what the maximum tolerable mass of a local anesthetic is. So for femoral catheters in the pre-ultrasound days, people ran these infusions at up to 12 mils per hour. And optimal volumes in the ultrasound era, there's very few studies that have actually studied this, have determined, say, for a femoral nerve catheter, that the ideal volume would be about 4 mils per hour. Once again, there is a bit of ambiguity to this. Now, if this were to be a catheter dropping local anesthetic on the nerve, this is the ideal situation that we think about when we place a catheter, that your catheter is sitting right on top of the nerve, but that isn't always the case. So if the catheter is inadvertently placed a little distance away, then you would have to use more and more volume to engulf the nerve. So once again, saying that 4 ml of local anesthetic is sufficient for a femoral nerve depends on how meticulously you have placed the catheter. So we heard about balance this morning, and there's always balance in regional anesthesia and your techniques. So the message is that if you are using low volumes, very, very low volumes, you need to keep a fairly high concentration of the local anesthetic. If you're using very high volumes, you must ensure that the mass of the local anesthetic is low. The ideal situation here would be to be somewhere in between the green zone, the balance between volume and the concentration. There's still gray areas to this. The skill of the operator and the techniques that we use are not clearly defined. They are also something that we cannot measure. Studies that have talked about volumes do not depict the proximity to the nerve where the local anesthetic was deposited. We are now going closer and closer to the nerve, going under those paraneural sheaths. We are not sure whether this actually reduces volume or should we be reducing volumes in this area. In conclusion, we also assume that the more favorable nerve block characteristics might be achieved by increasing the volume and the concentration of the drug, isn't it? We think that we want to give this guy a 24-hour nerve block, so we hammer him with 20 or 30 mils of 0.5 bupivacaine. So that in principle is all right, but and it's been shown repeatedly in literature that you can achieve that. You can, like in this paper, they looked at the interscalene block, and they found that the block would last longer if you use more concentration and more volume. But the converse is also true, that there are certain blocks and there are certain studies that state that it doesn't really matter if you use very high concentrations and high volumes, as long as you got the block going in some way. So this is a study on the sciatic nerve where they use 0.5% bupivacaine in varying doses, and they found that it doesn't make a difference if you use 10 ml to create a successful block or use 30 ml to create a successful block. So the key consideration is getting an appropriate dose. So with ultrasound, yes, we have come down with volumes, but it's unclear if this is the precise, if this is the optimal volume that we're dealing with. There is unpredictability in what we do, and this is the factor that has hampered our efforts to find the most accurate dose. So the cross-section of the nerve and assessing the area is a promising way to go, but it doesn't tell you what you should do if the patient has a neuropathy and the nerve is enlarged because of that. You wind up giving more dose on a neuropathic nerve and creating problems. So that is a problem with the cross-sectional area. So in conclusion, use ultra-low volumes only if you're an experienced practitioner or you're required to divide the dose between other blocks. Don't make the mistake of your block failing just because you gave a very low volume because you thought it was a nice thing to do. Consistent techniques, meticulous techniques will allow you to standardize doses at your workplace, avoid high volumes, especially with higher mass and concentration. And that's what we have learned with ultrasound in the last decade or so. Thank you.